Local anesthesia, posterior superior alveolar block. The equipment needed for this procedure is as follows: personal protective equipment, syringe, 25 or 27 gauge short needle, gauze, anesthetic cartridge, topical antiseptic, optional, topical anesthetic, cotton tip applicator, and hemostat or cotton pliers. The posterior superior alveolar, or PSA block, is used to achieve pulpal anesthesia in the maxillary third, second, and first molars in most patients. Thus, the PSA block is indicated when the dental procedure involves 2 or more maxillary molars or their associated periodontium and buccal gingival tissue. However, in approximately 28% of patients, the mesiobuccal root of the maxillary first molar is not innervated by the posterior superior alveolar nerve, but rather by the middle superior alveolar nerve. Therefore, a second injection to anesthetize the middle superior alveolar nerve is recommended after the PSA block to ensure pulpal anesthesia of all the roots of the maxillary first molar. The landmarks for this injection are the maxillary tuberosity, maxillary mucobuccal fold, maxillary second molar, maxillary occlusal plane, and the mid-sagittal plane. The deposit location or target area for the PSA block is the posterior superior alveolar nerve as it enters the maxilla through the posterior superior alveolar foramina on the maxilla's infratemporal surface. This area is posterosuperior and medial on the maxillary tuberosity. Load the local anesthetic syringe as demonstrated in the procedure, loading the metallic or plastic cartridge type syringe. Before the injection, follow all steps as demonstrated in the procedure basic injection technique. For the posterior superior alveolar block, assume the correct operator position for the right-handed clinician at 8 o'clock, right side, or 10 o'clock, left side, or the left-handed clinician at 4 o'clock, right side, or 2 o'clock, left side. Ask the supine patient to partially open his mouth and slide the mandible toward the injection side, opening the area for greater visibility. Retract the cheek vertically and not horizontally, pulling the tissue taut by using the index finger for intraoral retraction and the thumb for extraoral retraction on the dominant side for visibility and to help with the fulcrum. Palpate the injection site to ensure that only soft tissue is injected. Dry the penetration site and prepare the alveolar mucosal tissue with topical anesthetic in the vestibule at the height of the mucobuccal fold superior to the apex of the maxillary second molar. Topical anesthetics are most effective for patient comfort when applied for 1 to 2 minutes. Dry the tissue to remove any excess topical anesthetic. Using a 25 or 27 gauge short needle in the syringe with the dominant hand, orient the bevel of the needle away from the large window of the syringe as shown by the arrow on the needle to ensure bevel orientation toward the bone in case of accidental bone contact. A certain overall angulation of the needle to the injection site must be maintained throughout the injection. The angulation of the needle should be upward or superiorly at a 45-degree angle to the occlusal plane, inward or medially at a 45-degree angle to the occlusal plane, and backward or posteriorly from the mid-sagittal plane at a 45-degree angle to the long axis of the maxillary second molar. The insertion point is distal to the zygomatic process at the height of the mucobuccal fold of the maxillary second molar using all of these angulations. Establish a fulcrum by resting the syringe on the index finger or thumb that is retracting the cheek to ensure that the syringe is backward at a 45-degree angle from the mid-sagittal plane while the index finger or thumb rests on the zygomatic arch during retraction. Extend the syringe from the ipsilateral corner of the mouth, possibly pressing downward on the lower lip to maintain the angulations. When attempting the non-dominant side, the correct angulation may be harder to ascertain from across the patient's face. However, the needle should follow the same pathway as the non-dominant arm, always toward the surface of the maxilla and the operator's body. Retract the cheek by pulling the tissue taut with the thumb for intraoral retraction and with the index finger for extraoral retraction. Insert the needle at the height of the mucobuccal fold superior to the apex of the maxillary second molar and gently advance it in an upward, inward, and backward direction until you achieve the desired depth of the needle. Using a short needle at 16 millimeters or 3/4 the depth is recommended for most situations. The depth may be less for patients with smaller skull sizes or greater for those with larger skull sizes. You may need to adjust the angulation once the syringe is in the mouth, but before the needle enters the tissue. Do not move the needle in the tissue to establish correct angulation. You should feel no resistance or bony contact. If you contact bone, the syringe angulation is greater than 45 degrees backward, which causes the needle tip to be too far medial. To correct, remove the needle completely from the mouth and reposition the angle, decreasing it to 45 degrees. Due to the high vascularity in the area of anesthetic deposition, aspirate 3 times within different planes to ensure that the bevel of the needle is not abutted against the interior of a blood vessel, providing a false aspiration. First, aspirate as usual at the depth of penetration. If aspiration is negative, rotate the syringe barrel gently toward the operator and re-aspirate. If aspiration is negative, rotate the syringe barrel gently back to the original position and aspirate again. If a negative aspiration is achieved after each of the 3 aspirations, slowly deposit approximately 0.9 to 1.8 milliliters of solution, 1/2 to 1 cartridge, over approximately 60 to 120 seconds, and aspirate in the same plane after each 1/4 of the cartridge is administered. Carefully withdraw the syringe and immediately recap the needle using the one-handed scoop method with a needle sheath prop or other recapping device. Wait approximately 3 to 5 minutes until anesthesia takes effect before beginning treatment. Complications can occur if the needle is advanced too far distally into the tissue during a PSA block. The needle may penetrate the pterygoid plexus of the vein and the maxillary artery if overinserted, possibly causing a hematoma in the infratemporal fossa.